So welcome to Grand Rounds. I'm happy to introduce our speakers today. We have Dr. Waleed Kayani, who is an assistant professor of medicine and program director of Interventional Cardiology Fellowship Training Program at the Baylor College of Medicine. He also serves as the director of cardiac cath labs and chest pain program at Ben Taub in Houston. He's originally from Pakistan, where he graduated from Aga Khan University and completed his postgraduate training in medicine, cardiology, interventional cardiology at Baylor College of Medicine. Also joining us for the conversation after the lecture today is Dr. Falluji, our well-known system physician vice president for Common Spirit Health Cardiovascular Service Line, Dr. Falluji is an interventional cardiologist and practices in Lexington, Kentucky. So why don't we get started? Dr. Kayani, why don't you take it away?
Thank you for having me, Dr. McGinn and the whole team. It's a pleasure to be with everyone. Can you see my slides clearly?
Yes, we can.
Okay. I'm going to talk about a little bit about management of aortic stenosis, compare transcatheter aortic valve implantation and surgery. And hopefully by the end of this talk, we'll have some relative and important decision-making points for our general physician and for our cardiologists. I don't have any relevant financial disclosures for this presentation. I'm going to start to talk with the case that we dealt with earlier on our TAVI experience about 7 years ago now, who was referred to us by the primary care physician. This was a 65-year-old male who had a past medical history of hypertension, hyperlipidemia, coronary artery disease, and had undergone a bypass surgery about 8 years ago. He was also getting set to undergo radiation therapy for a recently diagnosis of primary cutaneous marginal B-cell lymphoma. His main presenting complaint to the primary care physician was worsening activity tolerance and dyspnea on exertion. He'd noticed that over the last few months, he was having trouble walking to his mailbox. The primary care physician had noticed the physical exam, which was noticeable for a murmur. It was a systolic murmur with an absent S2 and peaked in mid to lit systole and 3 out of 6 in intensity. He underwent an echocardiogram, which showed severe aortic stenosis and depressed ejection fraction, as you can see here for the non-cardiologists. This is the aortic valve. It doesn't open and close properly. It is a tri-leaflet valve, but it's heavily calcified and stenosed. And just to make matters a little bit more complicated, had a left ventricular thrombus also. His ejection fraction was 25 to 29. The gradient across the valve was on the lower side, but overall everything fit with severe symptomatic aortic stenosis. I'll come back to this case towards the end of my talk and update everyone on how we manage this particular patient. In terms of aortic stenosis, the most recent guidelines have staged aortic stenosis as A, B, C, and D. For simplicity, for management purposes, for the most part, we need to focus on stage D aortic stenosis, which could be either the severe high gradient symptomatic aortic stenosis. It could be symptomatic severe aortic stenosis with a low gradient and low ejection fraction, as was seen in our patient, or in some cases, severe symptomatic aortic stenosis with low flow, low gradient can even come with a normal ejection fraction. This is a slide from about 50 years ago, pertinent today even, where it tells us that patients with aortic stenosis, as they develop symptoms, their survival is very, very limited after that. You can estimate that about 2 to 3 years, majority of those patients, if they're symptomatic and not treated, would be dead. On the right side is the traditional surgical aortic valve replacement that's been done for about 60 years now. Our surgical colleagues have perfected it, and it was the front-running treatment till 2002 when Dr. Alain Cribier from France did the first retrograde aortic valve implantation through the femoral artery in a patient. Important point, since I'm from Baylor College of Medicine, is that one of my other colleagues across the street at the Veterans Hospital, Dr. David Peniagua, did something similar also, where Dr. Cribier was the first one to publish and got international fame for this particular procedure. This is data from the TVT registry showing that since FDA approval of transcatheter aortic valve implantation in 2011 and 12, the numbers have gone up significantly. In the blue here is shown how the TAVR procedure was initially approved and started for extreme and high-risk patients. But in 2015-16, when the intermediate risk TAVI was approved, these numbers continue to improve and increase. And then more recently, TAVR was also approved in the low-risk population. So now TAVI is being done across all strata of risk of patients of aortic stenosis. On the right side is the outcomes data that we've seen with aortic stenosis management through a transcatheter approach here in the United States. And as you can see, the mortality rates at 30 days, which were in the 5 to 7% range, are now significantly lower in the 1 to 2% range, at least based on this data from the TVT registry in 2020. Interesting to see that aortic stenosis bypassed isolated surgical aortic valve replacement as the predominant method of treating aortic stenosis in 2015. In 2018, it bypassed all forms of aortic stenosis management and valve replacements as the main therapy for treating aortic valve stenosis. I want to spend another minute on this slide for everyone to see that whereas the aortic valve replacement via transcatheter route has gone up significantly, the surgical numbers have not declined that much. Sure, there's a decline, but it hasn't gone down as much to compare with the rapidity of how TAVI has gone up. So I think it's safe to say that by implementing this technique, we're now able to serve patients who were before unable to be treated, were either considered very high risk or would have been just subjected to palliative care. This is a comparison slide of all the randomized clinical trial data for TAVI versus surgery in the balloon expandable and the self-expandable valve. We have the 5-year mortality data now available from the partner trials, the core VAV trials. And at every point, you can see that in terms of mortality, TAVI is very comparable to aortic, surgical aortic valve replacement. On the right side is the low-risk population. We have the 2-year data available for mortality. And again, TAVI fares out pretty well. So it's, I think, very safe to say, based on the randomized data that we have in the low risk at 2 years and in intermediate at high risk populations at 5 years, that TAVR is non-inferior compared to surgical aortic valve replacement. The same holds true for short-term mortality and short-term stroke outcomes as well, based on the randomized clinical trial data. Now, we all know people who've been a part of clinical trials and those who've been critiquing clinical trials over the years, that the population that's seen in clinical trials or enrolled is very select. Similarly, the sites that get to do clinical trials are very carefully chosen as well. I'm going to turn your attention now to the UK TAVI trial, something that me and Dr. McGinn talked about earlier this month, which was a pragmatic investigator-initiated trial done across all sites in the United Kingdom, where every patient that underwent TAVI in the United Kingdom was randomized or at least attempted to be randomized into this particular trial. This was publicly funded, as I said, and this also included all kinds of valves: balloon expandable, self-expandable, and any other valve that had a CE mark. In total, they enrolled 913 patients. The primary outcome that they looked at was mortality in 1 year, and the population of interest was patients who were deemed at an intermediate surgical risk. Looking at the baseline characteristics, the mean age or the median age of the patients was 81, which is slightly older than the partner and the TAVI trial here in the US, where the median age was about 75. As you can see, a good gender mix. Majority of the population enrolled was white. The STS score was 2.6. Just to put this into perspective, the STS score would put the patients in the low risk category. Looking at the primary outcome at 12 months, there was no significant difference in death from any cause, cardiovascular death, or a composite endpoint of death from any cause or non-fatal stroke between the two therapies across all sites and done by all investigators, as I said. Taking a deep dive into the outcomes, two things that I think we need to pay attention to was the significantly lower bleeding risk with the TAVI. However, the patients requiring permanent pacemaker with transcatheter aortic valve implantation was about 2 times that of patients that underwent surgical aortic valve replacements. Another signal that came out was a slight suggestion that the 1-year stroke risk may be slightly higher in the TAVI population. So what does the UK TAVI trial tell us about patients and their management with severe aortic stenosis? I think we can safely say that this trial was conducted in a clinical practice setting with multiple valve types, variable operative experience, and had a more inclusive population overall. And it confirmed the major findings of the previous randomized control trials, which were either limited to a specific site or to a specific valve type. It does support the current guideline recommendations for TAVI in older adults with symptoms due to severe aortic stenosis. So looking at the latest iteration of the ACC-AHA guidelines, we can see that patients with severe symptomatic aortic stenosis, which would be stage D of aortic stenosis, can get either SAVR or transcatheter aortic valve implantation. To look closely at who gets surgical aortic valve replacement or transcatheter aortic valve implantation, we can look at this slide. On the right side, if a patient is deemed high or prohibitive surgical risk, is frail or has more than 2 organ systems involved with significant impediment to a surgical valve replacement, TAVI gets a class 1 indication, especially if the valve anatomy is suitable and the transcatheter aortic valve implantation can be done through a transfemoral route. On the left-hand side would be the younger patients, especially the patients less than 50 years of age. We know that mechanical surgical valves theoretically can stay open forever as long as the patient takes their Coumadin. So their longevity is always going to be higher than a bioprosthetic valve. With bioprosthetic valves, we've seen that a 10-year mark is the inflection point where the valve performance starts to degenerate. So in patients less than 50 years of age, or whose life expectancy is greater than 20 years, and who can tolerate Coumadin, mechanical aortic valve replacement is the preferred therapy. In patients who have been considered for bioprosthetic aortic valve replacement, we have to look at the age based on the guidelines. If the age is greater than 80, transfemoral TAVI gets a class 1 indication. If the age is less than 65, or the expected survival is greater than 20 years, surgical aortic valve replacement gets the class 1 indication. It's a patient's age group between 65 to 80 who could either get a surgical aortic valve replacement or a transfemoral TAVI. Both are class 1 indications, depending on the heart team evaluation, patient's anatomy, patient's preferences. So what affects our choice today as we encounter these patients with severe aortic stenosis who could be candidates for either therapies? I think the first 2 questions that we ask ourselves are the age of the patient and the surgical risk. The choice is simpler in patients who are greater than 85 or have a high or prohibitive surgical risk. They go to TAVR or TAVI. In patients who are younger, who have a lower surgical risk and are good surgical candidates, are turned more towards the surgery side. But this is not as simple because we ask 5 other questions too, especially when we're choosing one therapy over the other. If the anatomy besides this is favorable for TAVR, whereby I mean there's less calcification of the valve and the left ventricular outflow tract, patient is favorable for a transfemoral approach because that's where the biggest benefit has been seen in trials. There's no other severe concomitant valvular disease, no other severe coronary artery disease that would mandate CABG in any case, or there's no other significant impediment to TAVR, those patients undergo TAVR. However, if there's more factors pointing in the surgical direction, patients are turned towards surgery. Coming back to our patient, this patient had D2, severe low flow, low gradient aortic stenosis with reduced ejection fraction. He was young for TAVR at 65 years of age. His risk profile, based on the Society of Thoracic Surgeon predicted risk of mortality, put him in the intermediate risk, much like the population that we discussed. But was that a true reflection of his operative risk? Because as I just mentioned, he's had a prior sternotomy. He's someone who is going to undergo radiation shortly. So probably his risk would have been higher. He had concomitant coronary artery disease that needed taken care of as well. So he had impediments to both TAVR and redo CABG/surgical aortic valve replacement. In the end, we decided to proceed with high-risk PCI followed by staged transcatheter aortic valve replacement in this particular patient. These are the pictures from his aortic valve replacement. He did great and continues to do well. So the take home, what does the data tell us? I think overall the data is encouraging, but before we make TAVI the default approach for treating aortic stenosis in all age groups, TAVI must show compelling data on morbidity, mortality, quality of life. I think based on what we've seen in terms of the trials, the first three questions have been answered, and TAVI has shown its promise in first three. The questions that remain to be answered remain the ones about the long-term durability and hemodynamic performance of the valve, the cost effectiveness of the valve, which will vary from the health system to health system and country to country. I can tell I practice in a public hospital system setting. And about 2 years ago, we were able to bring TAVI to our underserved population as well as one of the centers in the United States because it makes sense for us from a cost perspective. From a clinical and outcome point, the pacemaker rates with TAVI, as we've seen with all kind of experiences, is still significantly high. And especially as this therapy is going to be offered to lower risk patients, I think the pacemaker rates will probably have to go down. And then the last, which is more of a question, where there's some signal, at least based on the UK TAVI trial, of delayed strokes because of valve thrombosis or subclinical thrombosis that's been noticed on CT scans that will need to be carefully monitored. Till then, I think we need to go with our patient-specific heart team approach, keeping in mind patient preferences and comorbidities, and coming up with the right decision for every particular patient.
We're getting a lot of claps, so.
Sorry, I was on mute.
No,
yeah, so
fine.
if people have questions, you could put them in the Q&A or in the chat. I don't think we have any yet. I have one. We talked a little bit about this yesterday, and that is, could you talk about the next after 10 years, what happens, and both for TAVI and for surgical patients, the redos and the use of TAVI in that setting?
Yes. So excellent question. The first population would be the patients who've undergone surgical aortic valve replacement with a bioprosthetic valve, and their valve is now failing at 10, 15, 20 years. For those patients, valve-in-valve TAVI is the frontline approach, especially if the anatomy is feasible and favorable. So sending them to redo surgery really is not the preferred approach in the current day and age. And TAVI has definitely answered that question. Now, TAVI is the more niche approach. I can tell you honestly, from my experience, I have not done very many of those. It is still something that is under investigation at centers of excellence and high volume centers. It's being done, but it's not mainstream yet. And that's where the initial decision-making comes in and is very, very important. If you think that this patient is going to live long enough where the TAVI valve starts failing, then maybe going with the TAVI valve in the first place may not be the best approach. Or if the TAVI valve fails, maybe referring them to centers of excellence with operators have expertise to deal with that would be the way to go.
I'm sure everyone has a lot of questions. First of all, I think this is fabulous job. Love the presentation. And what I love is the evolution of the evidence as you move from, we started this back in the good old days. I remember sitting with cardiothoracic surgeons and interventionalists debating, should we be doing this in older adults that are, can't have surgery? And that answer is done. Now we're getting to intermediate. Now we're going to low risk. So it's just a fascinating evidence, evolution, which I like. And the way you've displayed that was, I think, just brilliant. Let me ask you a little bit of a fortune telling question. If I got rid of the pacemaker issue, right, let's make believe that was solved. What do you think that would look like in 5 years? Like, because to me, I've spent my life as an internist telling people, let's see, you got a little bit of symptoms, let's watch, let's wait, because we're always balancing the I'd say, like, if this was magically safe, why wouldn't I just take people with aortic valve issues and just start, fixing these things sooner? But anyway, I'm curious, maybe both Dr. Falluji and Dr. Kayani, if I could take away the pacemaker problem, we know it's, so what do you guys think? Maybe I'll let Dr. Kayani take a quick answer, and then Dr. Falluji, you take a jump at that. Yeah.
But agree with me. I think this part I can speak for both of us, that every single patient that comes to us wants a TAVI. They don't want their chest open.
They don't want their chest cracked open? I'm shocked to hear that,
They want the minimally invasive approach.
Absolutely.
I think the longevity of the valve is proven beyond the 10 to 15.
Right. Okay. So let's fix longevity and pacemaker. Do you think this could be take over? And also, would it also change our thought process about when to do it?
That's a very good question. I think the answer to the first question is yes. It's definitely, as the therapy and technology improves, as it has over the last 10 years, I think it will become the front runner, hopefully in the next decade or so, and become the default approach. The second one is more of an investigative question. I think it's being studied now actively in moderate to severe aortic stenosis population also, and the initial data is in.
That would make sense. So it is being studied. Sorry, Dr. Falluji, you were going to jump in.
Yeah, I think I will concur with my colleague. I think Waleed has put it succinctly here for us. I think, the moderate risk population is very interesting because it's going to give us an insight into a younger population, and we would have a longevity, so we will understand. Remember, the bioprosthetic surgical valve have problems too, and at 10 years they go down. The pacemaker rate should be put in perspective. It's not a significant risk, about 5%. And a lot of the times there is a way to predict ahead of time some of these patients. Some of them have ICDs, some of them biventricular pacers, so they already have a pacemaker. So it's actually—
Can I interrupt you for a second? So
yes.
It's 5%, but it's 25% high. So it's the baseline probability is low. So the increase is often low baseline probability. So that's why the 25% increase is a 25 off of a low baseline. Is that—
yes.
Okay.
You are. And actually, the bigger piece of that is we've learned that this is valve specific, so that what prosthetic you use matters. And even with the prosthetic, which is the Medtronic, proper techniques have resulted in a significant reduction from double digit to a single digit pacemaker. So, but I think the bigger question is, when you have someone with a stage 3 or stage 2 lung cancer, you don't tell them, go and come back when you're stage 4. And if you looked at the slide that we missed very quickly, the Braunwald slide from the 1968, before I was born, it says if you have the classic symptoms—
He had to put that in there. He was before he was born.
Because I want to keep up with you, Dr. McGinn.
Yeah. Okay. Thank you.
It says that if you have angina or heart failure or syncope, so these are the symptoms.
Right. Those are the ones we all learned in medical school. Yeah.
You're going to die quickly. But I will make the case that a lot of these patients slow down about 10 years before that. And they start to develop depression because of low—
I always found that very disturbing that I had to wait as an internist waiting for this to be done, and I think that to me would be a real quality of life change, that we would do this earlier. We don't have to have people, well, if you pass out again, to call me. I'm like, what is that? That's crazy.
Don't pass out again.
Yeah. I mean, I've had cardiologists, well, call me when he passes out again. I'm like, so anyway, thank you for that. I think it's an interesting question. And I just want to also do complete transparency of advertising. We have no cardiothoracic surgeons on this discussion. So we have 2 interventional cardiologists So but there's no bias. I just want to be very clear on that. So,
well, and let me just qualify this piece. The interventional cardiologists do not make the decisions.
I know.
Ankita and I were talking about that. We have a heart team approach. So when a patient comes, as you saw from the guidelines, this is a class 1 indication. Every patient is different. There are times when we push a 75-year-old to the cardiac
to get a surgeon. Yeah.
There's not enough calcium.
I think that's important to say, that it is a team approach, and that's the important thing. Dr. Sagar, you were about to say something, and I cut you off.
And I think I was going to tease out that thread that we had in our previous conversations about this is not a patient who just goes to a cardiologist and that cardiologist individually makes the decision. I think the importance of that team approach is really great, and I'm wondering from both of your perspectives, part of that team is that primary care physician who might not be involved in that initial conversation, right? So what are the things that you want primary care physicians and APPs to know when this is being discussed? I want you to tell the patient X, Y, Z.
Thank you for that question, Dr. Sagar. I think one thing that's been seen consistently in the data is that sometimes patients are not referred for these therapies, especially the patients who are not seen by cardiologists. They're either not sent or delayed with aortic stenosis to get to these centers. And this is any data set that you look at. So be vigilant. And when you find aortic stenosis, and as we've discussed, even at the moderate range, is where they need to be closely followed by the cardiologists. And just to go back to the previous point for a second, that remember that 40 millimeter gradient or that 4 meter per second jet is not a magic number. And more data is coming, especially in ladies and females, whereby it's being said that they may never mount those gradients. So waiting may not be the approach. So early referral to cardiologists, I think, is the way to go. Second, as you pointed out, the heart team approach or a team approach. I think what TAVI has taught us over the last decade or so is the importance of heart team approach. And not only for our patients with aortic stenosis, those are our patients with complex CAD, with complex mitral valve or any other valvulopathies. I think with the closeness that we've worked with our social work teams, our internists, our cardiac surgeons and us has just been amazing. I can tell you when we were training, it's like not a long time ago. I'm sure you will have better perspective on it, Dr. Falluji. Cardiologists and surgeons many times were like this. Now with the heart team, we drink coffee together whenever we have a heart team meeting. Many times we joke around and we co-manage these patients.
Still do that, though. That's part of it.
I think that's so important, the team effort here. Sorry, Gary.
I'm just going to say there's a question in the Q&A about, is a stenosed bicuspid valve considered unfavorable anatomy?
It's a great question. Yes. So whenever I teach my fellows, I tell them to look at the inclusion criteria in a trial for sure, but more importantly, look at the exclusion criteria of the trial as well, which is much bigger than the inclusion in many times, right? In general, they were excluded from the randomized trials. That being said, bicuspid valves now more and more, and I'm sure Dr. Falluji is treating quite a few of them also, are being offered TAVI. We just have to select them carefully based on their calcification, the type of the bicuspid valve that they have, and concomitant aortopathy, which is very commonly seen in these patients also. Dr. Falluji, you were going to say something?
No, I think that's the point. This is a unique population that we don't understand yet very well. It's an interesting area, but to your point, I think it's important to remember it's a disease of the aorta too. So aortopathy is a big piece here, and we need calcium. So that's another piece. A lot of the times these patients present early and typically with aortic insufficiency. And that's another area we haven't really well studied. And unless there is a prohibitive risk, a lot of the times they're better off going with surgical interventions. Now, sometimes they come from our colleagues in surgery because of what you've mentioned. There are many variables in the mix. Radiation, prior sternotomies for something weird that happened when they were young, because past people did that. Or
what is the overall percent of bicuspids, like of the aortic stenosis population? Like how many of them on average would, is that a number we know? Or I'm just trying to get a percent sense of back of the envelope here.
depend on the age group, Dr. McGinn. If you're looking at all comers, it would be 10% range, I'd say. If you're looking at the younger population in the 55, 60 years old, then it's going to be a higher.
Probably the higher, that's the driving, anatomy behind that. Let me ask one quick question. Why not a lower surgical morbidity mortality, or I'm not surgical, procedure mortality at that early 30-day, 1-year window in TAVR versus open? You would expect, right, that you would see, is it we just are not powered for that in the clinical trials? Or, my intuition would say, hey, this is much less invasive. They're going to show less mortality. Why not superiority, in a sense, is what I'm asking, right? So, and particularly in those near-term numbers. Any thoughts on that?
Yes, I remember when the low-risk trial was being done, Cleveland Clinic was one of the centers that was enrolling, and they joked that for the last so many years, they have not had a single mortality in this low-risk population for surgical aortic valve replacement. That's how good these centers of excellence for surgery are.
Right.
That's
the outcome. So the outcome numbers are too small, in a sense.
And if you look at the high risk and prohibitive risk population, there the data spoke for itself in the short term and the long term, with TAVI being non-inferior and in some cases superior.
Is that accurate, Dr. Falluji? Is that
not
inaccurate? I didn't mean to say that, but is that consistent with your thinking? Sorry.
Aortic valve surgery, I think, is one of the greatest surgeries we have today. It's still, hopefully that art is not going to be lost as we go forward with more TAVI.
Got it. Understood.
But in a lower risk population, this is a great surgery with a very low complication rate, apart from the 5 days or 6 days of agony in the hospital.
Got it.
I have one last, or maybe not last, but one. So you sort of intimated towards the end of your talk about this risk of thrombosis and stroke, relatively small, but you didn't actually put a magnitude on it. Are these brain dings, or are these like serious cerebrovascular events where people end up in wheelchairs and so forth? And so I wonder if you could just dig into that a little bit. And I've not heard anticoagulation come up, but how does that all fit together?
Yes, and I'll give my take, and I'll have Dr. Falluji give his perspective also. So if we look at patients, Dr. Greensweig, the two things that they're absolutely scared of are mortality and stroke. Yeah. So it's very important for all therapies that we offer that both these outcomes are very carefully tracked. Now, looking at stroke, most of them are subclinical leaflet thrombosis, and most of them are caught by MRI. There's some data that's about to come, and we've seen it at some conferences, is that some of these embolic protection devices during the procedure that can be done to decrease the short-term, even subclinical stroke risk. And then in the long term, there's some signal about valve-like leaflet thrombosis. And that's where the anticoagulant strategies are being studied. As you can imagine, this is a high-risk population. Every time you put them on anticoagulant, their bleeding risk is going to go high. And we've seen over the years that even bleeding can have significant morbidity. I think it's a question that needs further investigation and follow-up as far as TAVI is concerned.
Yeah, I think so. The patient that comes with atrial fibrillation and they're already on oral anticoagulation therapy happens to be a good patient because we feel comfortable just continuing that. Although, if you go by the European practices, they want Coumadin for 3 months. So they want them switched because there is evidence that that's better on the long term. Actually, we're becoming minimalist. So we used to push dual antiplatelet therapy for months and a year. And now we're doing single agent. And there's actually evidence that a baby aspirin is all you need. This is a high flow valve. So thrombosis here is not a common occurrence, but we do have a phenomena that we don't understand, which is that interferes with the valve function. It's not so much the people come back at 3 to 4 years with a thickening of the leaflet that is thrombus-based. And we just don't know why that happens and how do we address it right now. A stroke during the procedure is a big question. It's still, relatively speaking, low. And despite the use of embolic protections, which are very expensive, all we've seen is MRI significant signals, but no actual clinical meaningful strokes to your answer, Gary. There's not a whole lot of that. So the question is it a significant issue? As of now, it's not. Now, unless you have a major stroke, which is usually procedural, that's not a typical pattern that we see.
Okay.
Wow. Well, Gary, I'll let you say the final word, but I just want to thank both of them and everyone. This is a fabulous discussion, very thoughtful presentation, and Dr. Falluji's leadership in this space is, for Common Spirit, is very appreciated. And Dr. Kayani, nice to meet you. Yeah. I did not ask the questions that we as a health system are going to be asking ourselves, from a practical standpoint. What does this mean, for setting up TAVI programs as these become more prominent and prevalent? And what are the volume demand, what are we going to set as criteria to be a center to do this, right? This is the classic evolution of an intervention, right? As it becomes more commonplace, people start doing them in smaller hospitals. What is safe, what's not safe? And those are conversations Dr. Falluji is going to settle and solve across all of Common Spirit sometime by tomorrow.
I feel CMS has settled that for us too, Dr. McGinn.
They do, actually, yeah, but I think they're going to change. Yeah. They're going to change.
Yeah, they are, but they're very
anyway.
Yep.
Yeah.
All right, Gary. Thank you.
Thank you. And just one final comment. We talked about this yesterday. It doesn't seem that the number of surgical interventions for aortic stenosis is going down. They are sort of plateaued in that younger population, duration, so on. It seems that the TAVI interventions are going up, but the surgeons are still doing the same.
We're doing a lot of the stuff. A lot of the stuff we do is what the surgeons didn't do. So it's not
right. So you're adding people that you could not do but needed it.
Different segments.
So with that, I think we're at time. This has been a great morning and just so helpful, I think, for people. And we, Tom, you're going to say something.
No, I was just going to ask our two speakers to stay on after we stop the recording. Sorry, Gary, go ahead.
Okay, great. Thank you very much. It's been great. Thanks to all of our participants on the call. And in 2 weeks, we are doing what? Ankita and John.
We are doing post-COVID sequelae.
There you go. Dr. Shaib from Baylor. Great.
All right. Take care, everybody.
Thanks you, everybody.